Thanks sincerely, Michael. Lovely to meet you all, and I'm delighted to be invited to speak here today. I'm speaking on behalf of a large collaboration of academics, of clinicians, of researchers in palliative care education across Europe and more widely. And I'm here to talk about the findings and some of the outcomes of a large European project, a cost action project that's nearly 2 years into it now, and we have 2 years to go. So it's a 4-year project. So a little bit of a background to the project. We've had a lot of articulation of the need for quality palliative care for many years now. Even if you go back to the World Health Organization Palliative Care Resolution from 2014, there was a significant there was a very specific indicator relating to palliative care training, saying that basic training and continuing education in palliative care should be integrated as a routine element of all undergraduate medical and nursing professional education, and as part of in-service training of caregivers at the primary care level, including healthcare workers, caregivers addressing patients' spiritual needs, and social workers. So obviously in the last 10-15 years there's been huge advances in trying to progress palliative care education and initiatives. In 2021 then, the WHO published another document assessing the development of palliative care worldwide, a set of actionable indicators for quality palliative care education. And within that document, there were actually only 2 quality indicators relating to education specifically associated with palliative care. And as you can see here, the proportion of medical and nursing schools with palliative care formal education undergraduate curricula. And the second one was specialisation in palliative medicine for physicians. So as you can probably see, it was quite limited and very specific. Now these are very useful and measurable indicators, but I suppose the issue here is we need something more broad and something more all-encompassing and identify what are meaningful quality indicators for palliative care education. So that led to the initiation of this cost action project. And this is where the name came from. I didn't make up the name. It's a collaboratively developed and culturally appropriate and inclusive assessment tool for palliative care education, the CODIA tool. So the goal was to develop a tool whereby it could support institutions and people around how they can self-assess the quality of their palliative care education offerings, and a means to future plan and future-proof that too. So this is the initial team that developed the cost action, and you can see some members of the team there. And so we're about 2 years into the project now. I'm on the management committee of that project, and I led one of the research packages associated with that project. So that's what I'm going to focus on today. There are broad aims of this cost action, and I'm not going to go into all of them today, but I will show you the link to the cost action website, and you can look that up afterwards if you wish. But I'm really here today to talk about the first work package, which is the development of the CODIA tool. And obviously, as a first step of that, we needed to try and identify what actually are essential indicators of palliative care education. So to do that, we used the Donovan model for quality indicators: structure, process, outcome. So structural indicators relate to attributes and resources and infrastructure to deliver palliative care education. Process relates to methods and procedures used in the delivery for palliative care education. And then obviously outcome indicators are those effects on practitioners and receivers of education. So to do that, a very comprehensive strategy was put in place. So first of all, this is the whole development process, and it led to the culmination of a Delphi process, which I led. But over the past 2 years, there have been collaborative groups working across the cost action in parallel that developed the evidence and the initial candidate indicators that I took forward with a steering group in a consensus process. So the literature review was a large umbrella literature review, and that was conducted by a large group of people from Working Group 1, and it identified 32 candidate indicators from that data. Simultaneously, a group looked at protocols and guidelines, clinical guidance associated with palliative care education, and that actually yielded no quality indicators for palliative care education, when it in itself is quite an interesting finding. The third arm of the work that was done to develop these initial indicators was by expert opinion, and that happened in Yerevan last year, where a large group of the cost action met online and in person, and between them came up with 88 indicators of palliative care education. So a harmonisation meeting happened in December of last year, where representations of all the working groups of the cost action met and discussed all of those candidate indicators and removed duplicates or indicators that were similar from a construct and a theoretical point of view. And that identified an initial candidate list of 38 quality indicators for palliative care. So then it moved to me and my group, and 37 indicators. So you can see there, of the initial candidate indicators, there were 10 structural, 23 process, and 4 outcome indicators. So then we moved to a Delphi process, and that began in January of this year. And I led a steering group from working group 1 of that cost action. There was 19 members of us on that group. We obtained ethical approval from Dublin City University, and we conducted a 2-round electronic Delphi study. And for those of you not familiar with Delphi study, it's essentially a consensus building process. So experts are given a set of data, and they agree on a consensus of what is essential out of that data. So we conducted a 2-round electronic Delphi. We recruited internationally across the world. There were heterogeneous experts included, and that included researchers, educators, and clinicians associated with palliative care education. So there was a targeted sampling strategy. We targeted experts across all the WHO regions. We targeted experts who were key authors in palliative care education associated papers, and colleagues across the cost action as well. We hosted a survey on Qualtrics, and that was disseminated from March of last year. Now, we wanted to develop a culturally and relevant and inclusive set of indicators. So one of our other working groups took those initial indicators and checked them for plain language, because there's a lot of differences in culture and context, associated with the likes of curriculum and what a teacher is and things like that. So supporting material that we used for that Delphi, we identified 30 key terms that were explained in plain language as well to support that for the Delphi study. So just a quick summary of the Delphi process. We piloted it in March. I wasn't very popular at home on Paddy's Day piloting a survey. Round 1 happened in March until April, and round 2 finished in May. So I'm just very quickly going to give you the results of that. So we had a round 1 response rate of 199 experts, and in round 2 we had a response rate of 152. So we had a retention rate of 76.4, which is very acceptable for a Delphi study. 71% of our respondents across the globe were female, which is probably not surprising when you consider the demographics of who we were targeting. The vast majority of our respondents emanated from the European region, because most of the cost action membership was from the European region, and therefore snowballing typically occurred within the same region. But we do have representation across all regions of the WHO, and you can see there in the pie chart. So Asia, South America, USA, Africa, Australia, and New Zealand are all represented in that Delphi consensus process. And again, similar to the demographics of who we were targeting, most of the sample were physicians and nurses. But we do have representation across all of the allied health disciplines. About 84% were physicians and nurses. A very experienced sample. So you can see that about 64% of the respondents for this Delphi consensus process indicated that they had more than 10 years experience in palliative care education. So that was encouraging. And also respondents by type of expertise, it was varied. You know, most were clinically based in their palliative care education role, but there were also people who were in academic roles, people who were in 2 different roles, and people who were in research roles as well. So the result of that process was 36 quality indicators for palliative care that were identified. 10 of those were structural, and just to give you an example, that related to, for example, the compulsory presence of palliative care across undergraduate curricula, minimum teaching hours associated with palliative care, dedicated academic departments or professorships, and qualified faculty who deliver palliative care education. 22 were process indicators, so competency-based design, alignment with guidelines, WHO principles, inclusion of ethics, legal bereavement aspects. The consensus process, it was very clear that, you know, palliative care education should be interdisciplinary and interprofessional, and various teaching methods should be used, including simulation. And then finally, 4 outcome measures were identified as well, along with aligning with assessment, good assessment properties associated with palliative care, and very clear and transparent assessment methods, particularly in undergraduate. So that data was generated approximately around June. So the next steps of our cost action, we have already begun the testing phase for these quality indicators. That begun in August. And essentially what we have developed is a structured framework for assessing current provision and identifying gaps and guiding development of curricula and training programs aligned with best practices. The next phase of this study is to pilot test these quality indicators, again, across our cost membership for reliability, validity, applicability and relevance, and essentially getting more data around measurement properties associated with these quality indicators. So the next phase is very much a data-driven refinement of this initial list. So ultimately the goal is to develop a self-assessment tool, an online platform that will operationalize these quality indicators and facilitate reflective and evidence-informed dialogue amongst key stakeholders. So the cost action website details are there. It is still possible to actually join the cost action, and there are over 180 members across, I can't remember how many countries, there could be 20, 25 countries involved in this cost action. So it's still possible to join the cost action, and the details are there. Okay, so thank you very much for your time.